Hi, my name is Dr. Greta Hanson. I'm a laborist and the site director for a hospital in Massachusetts, and this is my life save story. A 40-year-old woman who'd had two other pregnancies was diagnosed with a miscarriage that had not passed a few days prior in the emergency room at our hospital. Another doctor had scheduled her for a routine treatment, which is a D&C, a routine suction, dilation, and curettage. She presented to the hospital for this procedure. She's a very healthy person, had had a history of a C-section, but really no other medical problems, no bleeding problems. She didn't have any signs of infection. So really the doctor felt it would be a very straightforward, low-risk procedure, as these usually are. However, when they got to the operating room and started the procedure, they noted significantly increased bleeding from the start. Bleeding is not uncommon, and they treated it appropriately with ensuring to continue to remove all the pregnancy tissue as well as give some medicines. However, they felt uncomfortable as the blood loss increased to about 1 liter and called me as the hospital OBGYN to come assist them in the operating room. I was able to get there within minutes, and the thoughts that go through my mind are, why is this happening? Why is she having extra bleeding? And it can be as simple as there's just still a little bit of pregnancy tissue there that needs to be removed. It can be much more serious, such as an abnormal pregnancy that can lead to a lot of bleeding, or perforation, meaning a hole was made in the uterine wall, the muscle of the uterus, or a significant infection leading to the increased bleeding. So all those things were in my mind as I got called and walking over. I had asked to have an ultrasound brought to the room to help visualize if needed. And after scrubbing in, my first step was to repeat the procedure, to just repeat the suction D&C to get a feel, to make sure I didn't feel like there was any further tissue, which I did not. I actually looked with ultrasound and confirmed that there was no more pregnancy tissue. And it did, the uterus contracted down, got small, but then quickly started filling again with blood. We could see it on the ultrasound machine. Thinking the next steps, I did, because at this point she had lost about 1,500 or 1.5 liters of blood and had become tachycardic. We asked for a unit of blood to be given. Something I had seen just a few times in my career is to place a pediatric Foley catheter, which is a catheter that's for children, and it has a balloon at the end of it, and to place that inside the uterus and blow it up so that it presses on the inside to kind of act like a tamponade or pressure from the inside of the uterus. Once that was done, actually, very quickly, the bleeding was stopped. We watched her in the operating room to make sure that it didn't start to increase before waking her up. Then we brought her back to the recovery room, and a few hours later, slowly released the fluid. She experienced no further bleeding. Her final blood loss was 1,700. We also treated with antibiotics to make sure there wasn't an underlying infection. And we gave her some estrogen just because she had had multiple procedures on the lining of her uterus. She went home the next day. Her hemoglobin did not drop further than the intra-op, so we had responded with the blood products appropriately. I think a lot of what OBHG is known for is the obstetrical emergencies that we are able to respond immediately to, but I have felt some of my most satisfying experiences have been to help with the emergency gynecology problems that women have.